All right, for those of you who are joining us, good morning, good afternoon. My name is Dawn Wyatt, and I'm very proud and honored to be introducing our webinar series. Let's talk about today's topic is health and reproductive rights. We've brought together an amazing collection of experts from UW Medicine. This series is brought to you by UW Medicine and a partnership with the Center for Women and Children, as well as our partners and producers of the Right is Rain publication. This has been part of a collection of series that we are bringing to you. And again, we're honored to have everyone participate in today's session. Just a few house cleaning things for those of you who are just joining. All participants are automatically placed on mute. And today, if you'd like to submit, this is very active and we want to make sure this is an engaged panel with you to answer your questions. At the bottom of your screen, you can submit those questions to the Q&A portion at the bottom of your screen, Zoom screen. So please all submit all questions through the Q&A section. You also have an option within the Q&A field to submit your questions anonymously should you want to. So none of your personal information or name would be provided in that. Another item just to note, how you are seeing all of our panelists as well as a collection of people who are helping us manage and run this webinar today. And so for those of you who want to just see our speakers and panelists, please note that at the top right corner of your screen, there's 3 dots that you can hide non-video participants. So that will include myself as I pan this over to our collection of speakers today. With that said, I am going to hand this off. And again, thank you everyone for joining. This webinar is being recorded and we will be pushing this out later in the week once we have completed today's session. So with that, I'd like to introduce Dr. Cutler to kick off our program today.
Good morning. I'm Dr. Cutler. My first name is Kristen. I'm one of the OBGYN chief residents at UW. It is my pleasure to introduce our speakers for today's panel, Health and Reproductive Rights. Thank you so much all for joining us, and thank you so much for those of you who sent some questions ahead of time. We will have some time at the end of this discussion to answer your questions, as well as review the Q&A in the chat. Our 3 panelists are Dr. Prager, Dr. Olatunde, and Dr. Ryan. Dr. Prager is the Division Director of Family Planning, as well as the Director of the Complex Family Planning Fellowship. She has a special interest in reproductive rights and is an advocate on the state and national level. She also has an interest in global health and helped start a family planning fellowship in Ethiopia in 2019. Dr. Olatunde is the Senior Family Planning Fellow at UW and has a special interest in advocacy as well as miscarriage management in the emergency room setting. Dr. Ryan is our new Reproductive Endocrinology and Infertility Division Chief, and she also has an interest in pediatric and adolescent gynecology. Without further ado, I will let our panelists start.
Hi, good morning and good afternoon, everybody. Thank you for that lovely introduction. And I have the pleasure of also handling our disclosures and acknowledgements because reproductive health is a tricky subject. And I want to start by recognizing that there is a plurality of people who access reproductive health care, including cisgender, transgender, and gender non-conforming individuals. And this can get kind of complicated for people, particularly people who would describe themselves as feminists and have really identified for a long time as a woman and as a feminist. And so I also want to honor the incredibly important role that women and those who identify as such have brought to the reproductive health and justice movements. And really just to restate, if it needs to be, that women remain the largest group of marginalized individuals in the United States and around the world. That said, we also acknowledge that women, particularly white women, have often excluded other marginalized populations during the fight for health and rights. And we want to really make sure that our efforts and our definitions can be inclusive of all without discounting and devaluing the important contributions of women to these movements. Next slide, please. a little bit of background that Dr. Ryan and I will be handling. First, more than 99% of people and women aged 15 to 44 who have ever had sexual intercourse have used at least one contraceptive method. So when we're talking about accessing contraception or some type of method to try to prevent or delay pregnancy, this is really something that is universal, and it's universal to everyone, men and women, and those who identify of any gender. Secondly, approximately 1 in 4 people in the United States has had an abortion during their life. And this ratio is actually higher if you look on a global setting. So we are not talking about a rare event. And if you get in any room of 100 people, a full quarter of them are going to have had an experience with an abortion. And I think we often think of this as a very marginalized procedure and event. And in fact, it's not. It's incredibly mainstream. Dr. Ryan?
Thanks, Dr. Prager, and thanks Dawn and Kristen for that great introduction. And I really appreciate being included in this panel, both because it's full of such distinguished advocates, and also because infertility care, infertility assistance is not so often found or positioned in the sort of broader reproductive health umbrella, and I think that's unfortunate because I think it's really appropriate and valuable for it to be so. And so again, I appreciate being included here and that we get to talk a little bit about infertility care and fertility assistance. As Sarah mentioned, there are things in reproductive health that are stigmatized, not talked about. Infertility is definitely one of those. And it's another one of those things that I think people who suffer with infertility or who require some fertility assistance for their family building really find themselves, once they reach out, finding out that there are many, many people out there who've been through the same issues. And so approximately 15 to 20% of all adults will have an experience with infertility in their lifetime. And fewer than 1 in 4 of those people will receive appropriate care for one reason or another. And this is unfortunately more likely for communities of color, and certainly more likely for single individuals and for trans individuals as well. I don't know, Sarah, if you want me to take the next bullet as well, or which I'm happy to do.
Sure, why don't you take that one?
Okay. And so also part of my work has been around access in general to care, to reproductive health care, but specifically also for access to again, infertility care. And part of my work has been as part of the American College for Obstetricians and Gynecologists, where as part of their ethics committee. And in taking part in that ethics committee and just in my daily experience, and I have some experience developing policies and procedures in my various positions, it really has come to light, I think, over the last 5 to 10 years that there are significant barriers to women with obesity, patients with obesity in accessing multidisciplinary comprehensive reproductive health care, and specifically some barriers set out for these people in infertility care. And that often arises from bias and stigmatization, both with, in the broader society, but also institutionally and also within providers. And I think it's really important that we as healthcare providers are aware of that as well and identify ways in which that has kept women out of appropriate healthcare.
Thank you, Dr. Ryan. And I would also just add that we see obesity being a stigmatized group in all areas of reproductive health. Certainly in the area of contraceptive management, there are some Most studies, I would say, are only for contraception, and anything else actually, are only done in people who are of normal weight. And then that leads to statements that various contraceptive methods are not appropriate for people who are overweight or obese. People sometimes will describe obesity as being a barrier for receiving certain types of contraception, also like an IUD. Sometimes exam tables, just to do a routine gynecologic exam, let alone an IUD insertion or something, has a weight limit. So for people who are over that weight limit, not all clinics can actually safely accommodate that. And certain facilities also for delivery care, obstetric and delivery care, will have a weight limit for patients because they don't want to risk potentially having to do a cesarean delivery in somebody who is significantly obese. The University of Washington doesn't have any of those limitations, and we often are the site that will receive patients who are over certain weight limits so that we can safely provide care for them at the time of their delivery or at the time that they are just receiving routine gynecologic care. Finally, just another stigmatized group that we have already acknowledged, but there's very little data on reproductive health access and needs in transgender men and women and gender nonconforming individuals. We are just starting to build a body of research around what those needs might be. And some of that research is actually happening with our colleagues here at the University of Washington. Next slide, please. I want to spend a couple of minutes now talking about what the current context is for patients. So there have been lots and lots of contraception and abortion concerns over the past 4 years, given the political situation. And I will say that during that time, we had any number of patients coming in and specifically requesting longer acting contraceptive methods so that they could make sure that they would have access to contraception through that particular presidential time period so that they wouldn't lose access. The Affordable Care Act, which went into effect in 2012, then allowed people to access contraception without a copay. So first of all, it's a misnomer to say it's free. People pay for insurance, but then there's no copay for certain things. And contraception, which falls under the category of preventive medicine, became one of those things with the Affordable Care Act. And so there was a lot of concern about that under the prior administration that would go away. And it really did dictate the decision-making that many people made about their contraception and about their fertility. There were a number of things that happened during that administration, including complete redefinition of Title X. And Title X is a program that funds contraception only for low-income individuals. It has never in its entire history funded abortion care, and it was restricted from being provided by clinics. Any clinic that also provides abortion care could no longer access that funding, even though none of that funding specifically would go towards abortion care. And we know that that program saves taxpayers $7 for every $1 invested, and that it actually saved federal and state governments $13.6 billion every year in healthcare costs. But that was irrelevant next to the ideologic motivations for changing what all of the rules and regulations were for Title X. So that's one example of changes that were made during the past administration that had real life implications of restricting access to contraception care for people. Then of course we have COVID, and the picture in the lower right hand part of the screen is a depiction of a COVID molecule. And we saw a lot of temporary shutdowns and restrictions of services from infertility and abortion clinics and lots of other types of healthcare, but specifically those two during the pandemic. And a lot of states that are less open to providing abortion care and good access to abortion care really used it as an opportunity to restrict abortion, like Texas immediately cut off any access to abortion care. Other states like Washington State, actually our governor made a point of saying that contraception and abortion, other reproductive health care is considered essential health care, and that access would not be restricted even when other types of health care were being restricted in the early parts of the pandemic. There were also some really innovative things that came out of the COVID pandemic timeframe in terms of lots of people really just didn't want to go to a clinic, and there was a lot of fear of presenting to clinics. And so in the reproductive health and family planning world, a lot of our colleagues really use this as an opportunity to expand something that has been under research and investigation for probably 2 decades now, which is essentially no-touch medication abortion, and utilizing telehealth, which exploded overnight, to be able to do patient assessments and then evaluate whether the medications for medication abortion could simply be either handed off in a kind of drive-by situation, or actually in some states mailed. And there were some state and federal changes to restrictions around these medications that allowed this to happen for a period of time, and also caused huge backlash in a lot of areas that really didn't want any type of expanded access to abortion care, even if it would be something that is to make access to medication abortion specifically safer for patients during a time of a global pandemic. What we hear now a lot from patients is that and what I will say have concerns over, is the potential negative impact on abortion specifically, but also contraception access and other types of reproductive health and justice by our current Supreme Court. We now have a majority court, 6 persons who are not really in favor of good access to reproductive health care, and 3 who are. And there are also a lot of concerns expressed by us and also by our patients about COVID-19 and racial inequity on safe pregnancy, parenting, and reproductive autonomy. And if you look in 2021, you can see that these concerns are incredibly well-founded. So this year, meaning since January 1st of 2021, over 500 abortion restrictions have been introduced in 44 states. In 3 months, over 500 abortion restrictions have been introduced in 44 states, and 12 of them have been enacted in 6 different states. One example, South Carolina just recently had their Senate Bill 1. So this is their #1 priority bill. That's why it gets that #1 designation. This was actually signed into law by their governor, and it bans most abortions. It requires providers to do an ultrasound, and it then requires that if a heartbeat is noted, which you can see a rudimentary heart flicker or some cardiac activity often sometime between the 6th and 7th week of pregnancy, at that point, abortion would only be legal per this new bill that was signed by their governor if it was a situation of life of the mother at risk or rape or incest. Now, of course, this was deemed immediately unconstitutional, and it has a temporary block while it is making its way through the courts. But this is just one example of an extreme measure that would restrict access to abortion care in the entire state of South Carolina. Another example of a state that is nearer to us that is reacting to some of the advances that were made around telehealth and no-touch medication abortion is that Montana has passed a law, House Bill 171, which bans telemedicine abortions. So this is in spite of data, both extremely recent from this past year as well as older data that indicates that complications including non-serious complications from telehealth medication abortion, are significantly less than 1%. And then many states are also adding anti-abortion language to their state constitutions. And in fact, 14 of these have been introduced this year in 14 different states, as well as various reflex laws that are being put into place in a number of states, so that if Roe v. Wade, which is the law that was that went through the Supreme Court in 1973, that allows legal access to abortion care across the country, if that were to be overturned, these reflex laws would then make abortion immediately illegal in the states that have these laws. Washington State, on the other hand, has made part of its constitution that abortion access is legal. And so if Roe v. Wade were to be overturned, the people in this state could still access safe, legal abortion care. And other states are also putting laws like ours into effect. In fact, last year, New York State was one of the ones most prominently that did this. But there really is some obvious concern for what the legal implications of our current world might be on reproductive health access. Next slide, please.
Thanks, Sarah, for that really great rundown of the current context for our patients. And so, as you heard, there are a number of reproductive injustices that are going on in this country and around the world. And when we think about these restrictions that exist, they really impact people from marginalized communities the most. And so those are people of color, low-income individuals, gender non-conforming individuals. And so it's really important for us to be very mindful of these restrictions and how they impact our patients, and thinking about how do we provide care with a reproductive justice framework and keeping those tenets in mind. And so the reproductive justice movement was created by a group of very insightful people of color, one of which is pictured here. This is Loretta Ross. And the basis of reproductive justice is that all people have a right to have a child, to not have a child, and to parent their children in safe and healthy environments. And so it shifts the conversation regarding pro-life and pro-choice, which is obviously a very important movement, and it's kind of been the historical movement in helping to move abortion access forward in our country. But it hasn't always been historically inclusive of marginalized communities. And so if we think about these abortion restrictions and how they impact marginalized communities, you know, it expands into having to parent a child that was unintended, having to do that in a safe and, you know, healthy environment. And how are we supporting these people, particularly when all of these restrictions are in place? Because, you know, if you're going to restrict abortion access, what are you going to do to help support inclusive access to childcare, access to food, access to clean water, et cetera, et cetera. And so it's really important to think about that in that mindset. Next slide, please. And so in addition to us providers ensuring that we use the reproductive justice framework to advocate for our patients, I also want to share with you the best ways to be your own self-advocate as well. Sometimes it can be hard to get what you need from your doctor's visit, and so hopefully this provides you a basis to do so. The first thing is to, of course, find a clinic or provider that you feel comfortable with. Obviously, your provider should be competent and confident, but they should also be very compassionate to your concerns. Bring your questions and do your research prior to your appointment, and this can help you to be very specific about what it is that you need from your providers. But it's also it's important to take what you find with a grain of salt. You know, as we know in this prior election cycle, there's a lot of good information, but there's also a lot of misinformation that exists out there in the internet. So it's important to come prepared so that your provider can guide you accordingly. And if there's anything that, you know, you bring that your provider may dispel, it's important that they do that with a compassionate mind. Sometimes it's hard to remember everything that's discussed or everything that you want asked, so it can be helpful to bring someone that you trust to your appointment. At this point, that's sometimes a little difficult to navigate given the current pandemic and limiting visitors and people coming in physically into the clinic, but that doesn't mean you can't have somebody with you, whether they're on FaceTime or on the phone. That's definitely appropriate and okay to ask your provider that you want somebody there with you, just to have another person by your side. And then last but not least, trust your gut. If you don't feel comfortable with a provider and if it doesn't feel right, you know, and I tell this to my patients all the time, I want my patients to feel supported when they leave and feel like their questions are answered. And if they don't feel that way, it's important for them to find a place that makes them feel that way. Next slide. So in summary, access to reproductive health care, including abortion, contraception, and fertility care, as well as general gynecology and obstetrics, is very critical for quality health care. We've learned that the current context of being able to access this care is a little precarious, particularly for people from marginalized communities. And it's important for us to uphold reproductive justice principles when discussing and managing reproductive health care for our patients. And that's it.
All right, thank you so much for the lovely discussion. There are a few questions in the chat that I wanted to direct to our panelists. One question is, what can people do to support the reproductive rights movement when elected officials / politicians throughout the country don't? How can we contribute to the movement in effective ways?
I'm happy to start with that one, and then Dr. Olatunde and Ryan, please jump in if you have other things to say. I think it is increasingly important to be very vocal politically. Everybody has the ability to be an advocate. Everybody has the ability to be political. And it actually does really matter one person's voice. I think a lot of times I hear, you know, it doesn't really matter if I send an email to my representative or my congressperson because, you know, who am I? I'm just one person. But it actually does matter. If they get 10,000 calls or 10,000 emails, that lets them know what their constituency is thinking and feeling. And it is incredibly important. And every private citizen has the ability, and I would say the responsibility to be an advocate for the things that you believe in. So I think that is one thing. And I would also say, I think we sometimes focus a little bit too large. We focus on what's happening on a presidential or a national level. And, you know, I say that it starts at the level of the dog catcher. If that were an elected position, you have to start small. Who are you putting on your school board? Who are your city council people? Because those are the people who are in a few more years going to be your state representatives and then your national representatives. And voting can no longer be taken for granted. I'm sure many of you have been aware of what's happening specifically in Georgia with all of the voting restriction laws that are being introduced. And I'll just say that there were, I want to say 80 introduced in Georgia, almost 80, I think it's not quite 80. And those were passed by Governor Kemp. And over 300 anti-voting laws or voter restriction laws have now been introduced or passed in states around the country. So this is the new thing. And I know we're talking about reproductive health, but the thing is, if you can't vote, then it's very difficult to have influence. And these are state voting laws that have to do with anything. It's not just who's going to be president. And so I would just try to inspire everybody to feel a sense of agency around being involved in the political process and know that your voice really does matter.
I'll also add that, you know, especially as we think about, you know, the last several months and how the racial justice movements kind of took over social media and our news, and sometimes it can feel overwhelming to think about how can I make an impact? It seems like everybody is doing so much and I'm doing so little, and it can feel really overwhelming. But I think starting small, not everybody is, got the horn in their hand, screaming out at every protest. Sometimes it's as simple as talking to your own community and dispelling myths within those communities. And that's where it starts, with your family, with your friends, and talking to them about why these things are important and not kind of brushing it aside. And sometimes that's even harder than walking down the street during a protest, but may have the much bigger impact.
I think that's also great. I completely agree with all of those comments. A few things that I would say to add to that are, it doesn't have to also be political. I think people are concerned that they don't want to take a stand that might be identified with one party or another party. I think what's often helped me is to think about it's the issue, to be very issue focused, and that is in fact what you're concerned about. And so it's an appropriate focus, and it takes it away from being a partisan issue. And I think that can make people feel more comfortable about that. The importance of voting has been really highlighted to me personally, just to share this, that I am from Canada. And so for many years, I didn't take the effort to become a citizen, to naturalize as a citizen. And then as I started to do more and more advocacy work, I thought, it finally struck me, I am talking the talk, but I'm not walking the walk and putting in the work to actually be able to vote. And it was just so powerful for me when I was finally able to vote. And so I completely agree with the idea of appreciating and putting into practice, your right and ability to vote whenever you can. I'd also encourage, I think it's so exciting to see the number of women and people from marginalized communities who are running, in elections, from, again, school board, all across the board, and in positions that have power locally, and then, can rise through the ranks or continue to make really important changes just in the local community. So that's been super, super exciting to see over these last years. And then finally, just having been part of some advocacy efforts, both at state levels and then at the federal level, I think if you have the opportunity to advocate, to show up if something has affected you, and just share your story, seems intimidating, but it is incredibly powerful. And often by getting connected with, advocacy organizations who can help you to do that advocacy, that small piece of showing up and raising your voice in those advocacy days and those opportunities to be there. There's nothing, I think, more effective for legislators than to see people in their regions show up and show the passion that they have for an effort. So I would encourage that as well, if at all possible.
Thank you for your answers, panelists. Another question that had come up, and Dr. Ryan, you may be able to speak to this, is the lack of insurance coverage for IVF and IUI, and how we can make changes as reproductive health advocates.
Yeah, that's an ongoing frustration, I would say, in the field, and lots of work is being done to try to improve that. One of the organizations that's really working together, the American Society for Reproductive Medicine, sort of our broad professional organization, is working with Resolve, which is, I think their tagline is National Infertility Support Organization. They're working together quite actively at state levels all across the country. And then at the federal level for veterans and military personnel to try to improve, coverage, insurance coverage, and support. So it is frustrating because, of course, when that happens, it affects, marginalized communities again. And so we have a really kind of a two-tiered system of infertility care sometimes. And it's tricky because there are states where there's mandatory insurance coverage, but that's varies completely. That can be anywhere from, well, only large companies are required to provide some insurance coverage for infertility, and it may be small, like just for testing, but not treatment. And so even these mandates may not reach many people depending on how they're written. There's also a real lack of coverage at this point for fertility preservation for cancer patients, or for patients who are facing any types of loss of their eggs or sperm, and that's also affects the trans community. And so there are efforts being made, again, through organizations like Resolve, ASRM, the National Association for Fertility Preservation. There's some great organizations out there working on that. And so I think lending voices and monetary support to those efforts, again, there are advocacy days for that. There are local also efforts being made. You know, for example, our clinic made the effort, lobbied to the university to lobby for a discount rate for folks who are, for example, facing cancer treatment or other gonadotoxic treatments, and also for employees at the university. And so that has gone through, and that's been really effective. And I think the important part about that is that then shows, it sets a precedent for other employers, you know, and other large organizations to do the same thing and identify that it's a priority for their employees.
Thank you, Dr. Ryan. Another question that came up in the chat, with religious belief currently waning, do we believe that this will provide for more body autonomy in the coming generations?
I'll start with that one too, if I may. This is probably going to sound a little bit cynical, but I think no. I think it's actually going to lead to more problems initially, because what we see when institutions and organizations that hold a lot of power are being threatened, they respond by holding on more tightly often. And I think that might be partly why we are seeing some of these backlashes and pendulum swings that are more restrictive towards women, towards reproductive health care, abortion and contraception specifically, but really anything, is because some of these institutions that have held power for a long time are recognizing that they are losing some power. I do think young people very much assume that they have bodily autonomy in ways that is different than prior generations. And I think that will ultimately help create change, but not without changing the system. And so this is sort of like what Dr. Olatunde was talking about, and Dr. Ryan also mentioning, just, you know, you really have to have systemic and system level changes in place before you see real change.
But I'll just add, just to counter some of the cynicism, because I see it, but I also see the other end of it, and seeing the way young people talk about their bodies and the autonomy they have in a way that I never was able to talk about. And there's definitely a paradigm shift happening. I'm not saying it's going to happen overnight or even in my lifetime, but I think it's there and moving. And I think these were same conversations that were being held in regards to lesbian and gay rights in you know, several years ago. And I think there was probably that same kind of contention. And now we are moving the needle even more when talking about transgender rights. And so I think it's pushing in the right direction, and all we can do is hope that the systems in place adapt. But it's true, people with power love to hold on to their power. and not give it up to anybody else, because that's just the way things have been. But I think the younger generations are really pushing forward that their power is a little bit more meaningless than they think. So I'm hoping that will help.
Thank you. Thanks for that question too. One question that came up before is, please address one's ability to decline medical intervention on labor and delivery. And I thought that this was a really great question because birth and the birth experience is a critical part of reproductive health. And so I thought I'd briefly speak to this as a provider who's often on labor and delivery. And I agree with Dr. Olatunde in that it's really important to make your wishes known and have those discussions with your provider. And it's always good to have those discussions ahead of time, as well as on labor and delivery. And I think starting with an obstetrician that you feel really comfortable with, so you can have these really important conversations early on.
Yeah, absolutely, Dr. Cutler. And, I think it starts in the exam room before you show up on labor and delivery, and having a really well thought out conversation about your goals when you're on labor and delivery, what you're hoping for. And hopefully your provider also talks to you about that things on labor and delivery can be unexpected and can be unpredictable, and preparing you for that as well. But ultimately, it's your decision to decline any sort of intervention that does not sit well with you. And it's our responsibility to counsel you about the risks and benefits of certain decisions, but ultimately, support you through whatever decision it is that you make. But really, I think it starts before coming to labor and delivery in having those conversations with a provider that you trust.
Thank you. We have a question from one of the attendees regarding, I added Reproductive Justice by Loretta Ross to my reading list. Are there other books you would recommend to get informed?
I'm actually answering that in the chat right now, so I'll post a few ideas there. So it might be a little bit easier to read than me just saying them. There is a really broad spectrum of books. I'll say the ones I'm mentioning that I'm writing down, and then Dr. Olatunde and Dr. Ryan, if you have other thoughts as well, you can put them in there. Killing the Black Body is a really great book. Medical Bondage is another one. And then one that is specific about abortion is called Scarlet A, and it's written by a lawyer and ethicist. She's trained in both. And it's really talking about the ethics, law, and politics around the ordinary abortion. And that gets to a whole other discussion around abortion care, where we often talk about and highlight certain kinds of abortion as being more acceptable than other kinds of abortion, like if it's for a fetal anomaly or the mother is sick or whatever we want to say is like a more acceptable reason to have an abortion, as opposed to the majority of people have an abortion because they need to have an abortion. And so it's a very interesting read that is more specific just to that too. So I'll put those in the chat, and then others can put others in as well.
Thank you. And Juliana, one of our attendees, had a question kind of along those lines, but for resources for being a parent of 3 young children, and maybe some movies or resources for starting this conversation with young children.
I don't have any young children, but I do follow a social media on Instagram. It's called The Conscious Kid, and it's an organization that focuses on how to teach anti-racism to youth. And their website has a lot of great books and resources. I've used it to buy books for friends who are having children and things like that. So I think that's a great resource, and I can type it into the chat as well.
I would also, I have 3 daughters. I've always appreciated, and I can't, the names of some of the books don't come to me this quickly, but amightygirl.com is a great resource I find for finding books, you know, about and by powerful women and girls. And they have hundreds and hundreds of recommendations, and it's age-based, and then also topic-based. So they do a great job for different ages of girls and adolescents. And then, so, you know, my thoughts go to my work in bioethics and feminism and bioethics, which can be a little bit of a slog sometimes, those books, but I'm happy to put some of my favorites also in the chat as well. If you're thinking about something more along the lines of kind of, you know, yeah, again about a feminist bioethics approach to reproduction or reproductive technology, or sort of I think there's some really interesting discussion around kind of what it means to be a feminist and think about reproduction, because society can tend to be quite pro-natalist, and there's a big push now for women to have the ability to, say, for example, freeze, cryopreserve oocytes so that they can defer childbearing until, you know, it's appropriate in their particular lives and careers. And that is sort of quite a controversial topic in sort of feminist circles because of concerns about that being pro-natalist and versus actually opening up opportunities. So anyway, there's some really interesting conversations around what reproductive technology does to the body, and what kind of pressures it puts on. So I can type a few of those into the chat as well.
And I also have a daughter. She is no longer young. She just turned 16. But I will say, just in terms of, I guess she's still young, but not, she would no longer think she's young. I would just like to encourage anybody who has young children, boys or girls, to try to have a really open mind when your kids are asking you questions. And if you don't know the answer to something, I think it's totally okay to say that. And then you can ask their pediatrician or a friend or, you know, anybody who might know for the answer and how to kind of present it in an age appropriate way. But I kind of made a vow to myself when my child was really young that I was always going to answer her questions truthfully. Although I also reserved the right to say, that's private, when she would ask specific details about me. And I sometimes saved that until she was older, or, you know, not at all. And I have found that was really helpful in helping her feel like there's no question that is shameful, and to hopefully just present, you know, try to present an attitude that whatever she's thinking or questioning or asking is totally fine. So anyway, that was an approach that I took, if that's helpful. And yes, it's hard not to giggle sometimes, but I would not. I would save it for later.
I love that, Dr. Berger. One of our other attendees is asking, as medical providers, what changes would you like to see within the medical system / medical industrial complex to minimize reproductive harm and promote reproductive well-being?
I'll jump in, but I think all of us probably have things to say about that. This may be controversial, but I will say that universal healthcare would go a long way. I think healthcare is a human right. I don't think it is a privilege, and it is treated as such in our society, unfortunately. And we don't have actually a great human rights infrastructure legally in the United States. We're much more focused on individual rights than we are on human rights as a country, and with our specific legal system. And I think that influences certain things like our openness to universal health coverage. Universal education would be another thing that I think would go a long way towards more equitable access to care of all kind, and more equitable access to health, not just healthcare services. Anyway, I'm going to stop there, but those are two things that I actually think would really be useful.
I think you can say a lot of different things that aren't related to healthcare to help improve healthcare, because there are a lot of systems in place that have been set up to be inequitable from the get-go, which as a result are impacting our health. And so not only overhaul of our healthcare system, but of our government, of our education, of our, the way we hire and the way we give people housing and affordable housing, and all of those things, I think, need a huge overhaul. And so I chuckle because it's a very big question, but it's a very good question, because there's so much that I think needs to be done in order to really improve reproductive health and well-being for all people. So we've got a lot of work to do. I'll make sure to add that to my to-do list.
Those are great responses. Yeah, that's a huge question. And I totally agree. As a Canadian who grew up and experienced universal health care and just recently spent 6 months in the UK, where they welcomed our family with open arms for 6 months to provide us with health care, even though we were only there temporarily. It just really strikes me how very key that is, to overall health and well-being for our communities. It's ridiculous that people go bankrupt over their health care. And I think also that I totally agree with Sarah's point about the universal education and preschool education, because I think that feeds into it in improving, our overall understanding about reproductive health, which is lacking because of various political and educational limits as well. So we have a population that has to reach out for their better understanding of their own bodies and reproductive health, because it's not provided for them because of various, lack of availability. So I totally agree.
Thank you. I think we probably have time for one more question, and this kind of goes along the line of what Dr. Prager was saying earlier about information that we have regarding contraception and various like with obesity in various populations. So this question is about, can you talk about ways to advocate for better research for women in reproductive health? And it feels like a lot of issues are not well understood, especially when they don't respond to typical treatments, mostly, surrounding women's health issues such as endometriosis, chronic pain. And so I'm hoping you can speak to that, as we have all of our panelists are researchers as well.
I'll say a couple things, but I know both of you have other things to say. This is actually a really huge issue. And if you look at national organizations that fund research, like the National Institute of Health, pennies on the dollar are spent on women and children's research areas as compared to other research areas. And so that is one major issue, is that those, healthcare for women and children has just been devalued kind of from the get-go. I think being vocal in the lay press is one way to start. And I'll give one example, which is that I am seeing a lot more in the lay press around early pregnancy loss and how horrible that experience is for a lot of people, particularly in certain circumstances. And Dr. Olatunde is studying this also. And it is leading very slowly, admittedly, but towards a bit of a shift in terms of the interest in funding good research into these areas. So the NIH is not immune to topics that are, for lack of a better word, sexy or trending in the lay press, in social media, etc. And, you know, when Chrissy Teigen and Meghan Markle are blogging about their miscarriages, it makes a difference. And the, you know, hundreds of thousands of other people, unfortunately, who are also experiencing pregnancy loss. I think that's just one example of seeing that needle extremely slowly, but actually shift a little bit. And I think that could also be true for other very understudied issues like endometriosis and things that are other areas specific to reproductive health care.
I think also as researchers, we have to shift our mindset on how we do our research. And so this is, you know, a plug for community-based participatory research, and where you go to the communities that are impacted by the condition you want to study and reaching out to them and being like, what questions is it that you want answered? What is it that you want us to know about your condition and how it impacts XYZ, you know, your abilities to get pregnant, your interests in contraception and what works best for you, and really shifting how we do research from just, you know, the goal of getting published and name recognition, but actually impacting the communities that you're researching. So that's the only thing I'll add.
Yeah, that's great. I would also add that the NIH actually has a policy that women and minority groups should not be excluded from clinical trials unless, or from any clinical research funded by the NIH, you know, unless there's a good reason to do so. So I think that's an important change that happened in actually a fair amount of time ago that set a good precedent. So I think it's also important to, you know, for those of us in positions where we can advocate for those types of changes, that we do that. Unfortunately, and then that has to though trickle down, and you know, the NIH does not have an institute or multiple institutes that actually generally represent classic women's healthcare issues very well, on the other hand, and so in general, women's health doesn't get a lot of funding from the NIH compared to other types of research, and so thus limiting the impact that has. But it can and should trickle down to local institutional review boards and places where they then require these smaller studies on local levels to have equal representation, at least. The other thing I would just point out too is that I was thinking about that, Sarah, when you were, you know, talking about listening to voices. I think that too often we look at all of these quantitative research things, studies, and we try to force you know, sort of women into these boxes that have been made in the past by a past traditional medical structure, when really we need to be starting to listen to women's voices to help guide research directions. And I think that we really need to listen to our anthropology and our nursing colleagues who have been doing that for, you know, decades, and then like raise up that kind of research so that it gets the kind of recognition that it deserves as well, because there's great things to be learned, and that should really be the guidance, not sort of what's been done in the past and what's been valued as good research.
Thank you.
Thank you. Thank you, everyone. Thank you to our panelists. Thank you to all of the questions that came through today. This was an amazing conversation. And again, thank you, everyone, for jumping on today for our program. This will be recorded and pushed back out, and please send us any additional questions that you may have. Our next series is going to take place in April. It is the topic for next month is Let's Talk About Midwives. So we hope that everyone who participated today has an opportunity to join that. I want to give my sincere thanks to our experts and the panelists today, one for just this thoughtful conversation and sharing information out with our broader community. So thank you, everyone, and have a good day.
Thanks, Dawn.
Thanks.